Over the next 3 years, this performance improvement project will be focusing on addressing the complexities of co-occurring diabetes and depression. From our research, there appears to be a bidirectional relationship between diabetes and depression. A person with diabetes is at an increased risk of depression, and a person with depression is at an increased risk of getting type 2 diabetes. All plans across the U.S. serving Medicaid members are required to do a PIP. DHS collaborated with us to establish this as a priority project. All plans have multiple initiatives in place to address these conditions, but the PIP allows us to formalize this work and to collaborate on interventions to bring them statewide. This project is designed to improve the quality of care and health outcomes for Medicaid members, address a serious health condition, improve member satisfaction with a goal to achieve improvement sustained over time. And this PIP addresses all of these areas. We will have time for question and answer at the end, but also potentially be able to answer pertinent questions at the time. Today's presenters are both from our health plan at Health Partners. One is the leader in behavioral health, and the other one is a medical director who is also, both of them are also practicing physicians. And from the feedback, we are very excited that they are bringing their medical and mental health expertise to this webinar. Again, thank you, Dr. Spilsas and Dr. Palmer, for presenting today.
Hi, everyone. Thank you for joining us today. Like Tammy said, I am Sarah Spilseth, and I'm a Medical Director, Health Plan Quality for Health Partners, and a practicing internist. With me, I have Dr. Palmer, who's going to make sure he unmutes himself. Today, we are going to here's our outline for today. We have 3 cases. In these 3 cases, we hope to bring you a wealth of information, including what is diabetes, what is depression, and most importantly, how do they interact together? In case 2, we're going to kind of look at what's the difference between being truly depressed versus frustrated, and then what are some motivational strategies we can use to help our members and patients with this. And then finally, in our last case, we're going to dive into what are some of those social and cost drivers that can lead to both worsening of depression and diabetes. So with that, let's move on. To start, diabetes, depression. So the global prevalence of type 2 diabetes is about 10.5%. So 1 in 10 people you see likely has diabetes. This is increasing. A lot of that is driven by our increasing rates of obesity, but there's also a genetic component as well. And unfortunately, we definitely see increased prevalence among our members and patients that are Black, Asian, and Hispanic. Now, from a depression, at any one point in time, 5% of people are suffering from depression. However, the lifetime prevalence of depression is more around 15%. This is much more common in women, with 50% more women experiencing depression than men. And despite very effective treatments, more than 75% of those affected remain untreated. And so really going in, okay, how do these interplay? Managing diabetes is stressful. And unfortunately, it can lead to symptoms and exacerbation of depression. Finally, also, diabetes can lead to complications that can worsen depression. We're going to see that in some of our cases today. And then finally, depression can make it really difficult to do tasks, communicate, and think clearly, which of course is just going to make it even harder to manage the complex disease that is diabetes. So moving on, we're going to jump to our first case. Dr. Palmer.
All right. So going to dive into the case. Heads up at the beginning, there will be 4 choices of how to proceed. None of them are wrong. So we're going to use the case to try to focus on some teaching points. We have one answer that we do think is the best, but just lower the stress. This is not a quiz. No one's being graded. It just helps guide our discussion. So let's consider 34-year-old English-speaking Hmong man with type 1 diabetes, hospitalized. Perhaps he was hospitalized under care of a psychiatrist like me for severe depression and thoughts of suicide. After he had overtaken, maybe he was overdosing, maybe he just took too much, his insulin. He has advanced diabetes, severe visual impairment, renal insufficiency, and poorly controlled hypertension. His current hemoglobin A1C is 9. He's not able to work because of the vision. He's on disability. The mother of his son and his son have moved out of state. And he does brighten when he talks about his son's success as captain of the hockey team. But the patient hasn't been able to see a game this year, and he only speaks to his son once every few months. The patient shared that as a kid, he loved playing hockey too. You assess that depression, and he does endorse that his mood is depressed. He has anhedonia. He's not able to enjoy things. And this has been persisting now for several months. He has few or really no interests and spends the day inside. He frequently cries. He thinks about his regrets as a father and wishes he could be there for his son. He doesn't want to die, but at times thinks it would be easier or just best to get it over with. And in his darkest moments, he acknowledges he mismanages his insulin to intentionally go low, wondering if he would die. He struggles to fall asleep at night, and he wakes frequently overnight. He was previously on an antidepressant called citalopram or Celexa, but it helped him, but he stopped taking it. So you, his case manager, care coordinator, care team member, you're working to build a relationship and sort out how you can be most helpful to him. So which of these 4 questions would you ask? And be aware of how we've even constructed the question of whether it would be an appropriate way to proceed. 1, have you considered that if your diabetes was better managed and your hemoglobin A1C was lower, your depression would be better? Number 2, depression can lower libido, and diabetes can impact sexual functioning. Amid everything else, how are you feeling sexually? Number 3, how does Hmong culture understand suicide? Number 4, it seems like being there for your son is important to you. Have you thought about how your death would impact him? Again, none of these are horrible things to say. They all could be appropriate in context, but Dr. Spilseth and I think one of them is probably the most appropriate choice. And you can just click the bubble next to the choice you prefer.
Do we have the polling results quite yet?
Yeah, it looks like about 70% have participated, and we have a couple more rolling in, but I can end the poll and share responses.
Thank you. This is going to get fun as we go. All right. So we will tell you toward the end what we think is the most correct answer. But let's cover the content around this first section, which is the interface between diabetes and what diabetes is and how it affects things. So we'll continue on.
Sounds good. All right. So moving on to our next slide. There we go. So what is diabetes? Almost all of you know there's a type 1 and a type 2. When we think of our younger patients, this is frequently when we're thinking about our type 1 diabetes. So type 1, typically autoimmune. This is about 5 to 10% of our diabetic patients, typically presents in childhood or young adulthood. Now, this is one where oral treatment is not an option. These patients really do have to be treated with insulin. And here is when we frequently see, sometimes as the presenting symptom, might be diabetic ketoacidosis, which requires hospitalization. This will be a lifelong illness for these patients. Now, when we think of type 2 diabetes, this is actually resistance to insulin, and it can be in a variable degree. So not everybody has the same degree of resistance to insulin. This is, as you might expect, the most common type of diabetes, and it's also the most common type that we find in adults. There are many, many, many treatment options available for these patients, including oral therapy as well. Diabetic ketoacidosis is less common in these patients, and in some people, weight loss can be curative. Now, when we think about complications of diabetes, even before we get into the nitty gritty, one way I like to visualize this is think of it as insulin layering on top of those blood vessels. And once you think of that, you can pretty quickly imagine what the complications might be. So in the brain, when we see that layering of glucose, on those blood vessels, frequently that would lead to stroke. It could lead to cerebral vascular disease, including some forms of dementia. In the heart, we might see cardiovascular disease that would present as a heart attack. In the kidneys, very commonly, we'll see patients who will develop acute kidney injury, chronic kidney disease, both of those we can see. Many of our patients will go on to develop diabetic nephropathy, numbness in the feet. And unfortunately, those can lead to really awful sores on the bottom of the feet. In the eyes, we see diabetic retinopathy, cataracts, and glaucoma. This is a dental disease as well. And then in the peripheral vascular disease, we see glucose on those blood vessels as well, which, like I said, can lead to really bad foot damage and just the inability to effectively heal wounds. Dr. Palmer, why don't you tell us, what is depression?
Yeah, so I love that explanation, Dr. Sposeth. If we think about those small blood vessels, like the small blood vessels anywhere in the body, that's where the complications of diabetes come from. It's a disease of blood vessels. That was really a helpful way to talk about it. On the mental health side, depression, I think most people on this call would be familiar that we think about a depressive episode, something that comes on that's a departure from normal, requires depressed mood and anhedonia lasting a couple of weeks, and includes the SIGI CAP symptoms that I think most people are probably familiar with, either increased sleep or decreased sleep, decreased interest in activities, feeling guilty, having low energy, impaired concentration, appetite changes, which could be increased in some depressions or decreased in other depressions. The psychomotor changes, usually that's a slowing. Sometimes it can be an activation. And suicidal thoughts. Most people are familiar with that. I'm going to suggest today that we also think about SIGI CAP's role. And that libido is affected by depression and is often not asked about. We're going to use medications that sometimes affect libido. And I think it's going to be important that we think about that, particularly in diabetes, because there's an overlap with blood vessel disease that's going to affect libido as a complication of diabetes and a complication of depression. So depression can be mild, moderate, or severe. It has to impact functioning to make a diagnosis, and we label it persistent if it's lasted for 2 or more years. It's not the same as grief. It's not the same as feeling demoralized. It's an illness that is a departure from normal, not just a reaction to a bad day. I think in medical illness, it gets a little tricky. And so if you think about, say, somebody with cancer and they're going through chemotherapy, somebody with diabetes who's having medical complications, we see a lot of things that can look like depression. And so instead of just focusing on the list, I try to also think about, what's the core phenomenon? So the first thing I try to think about is this reactivity of affect. Like, does someone, if the grandkids walk into the room, do they perk up or do they still stay pretty flat? That really is a marker of depression rather than just side effects from chemotherapy or those kinds of things that could make life hard. Second is this brooding or tearfulness. Again, lots of people go through medical complications. They're overwhelmed by them, but most people actually don't get self-pitying or brooding or tearful in that process. Third, negative self-appraisal, viewing yourself as bad or flawed or wrong. And fourth is social withdrawal, pulling away from people. So those things are important. A departure from normal where there's a lack of affective reactivity, an increased sadness that can travel with that. And I never miss a chance to mention, if you're going to think about depression, you're always thinking, is this unipolar depression, meaning one pole, the downside of a pole, or bipolar, meaning two poles. In bipolar, there's mania as well. Depression can look the same in bipolar disorder or in major depressive disorder, but they're treated differently. The treatments we use for major depressive disorder are different than the treatments we use for bipolar depression. So always thinking, has the person ever had a manic episode? And as you noted at the beginning, more common in women than men.
So how do they interact? And the thing is, these co-occur frequently. In fact, people with diabetes are 3 times higher likelihood to have depression. And in our type 2 diabetics, they're 2 times higher risk of depression. And they worsen with each other. So poor glycemic control worsens depression. And this makes sense, right? So you're developing complications, stressors, losses. It would make sense that that would only make the depression worse. And then depression worsens glycemic control. So here we're not taking care of ourselves. Perhaps we're not taking our medications. We don't have the motivation to do these things. We're perhaps isolating ourselves from those who support us and decrease activity as well. But the good thing, the positive thing in here is that the treatment of each improves the other. So as we treat that depression, we see that that A1C goes down. As that A1C improves, we see that the depression improves. So this is really something that we need to be thinking of positively. We know that if we can get control of one of them, we're more likely to be able to get control of the other one as well. Let's go back to our case. Dr. Palmer, you want to
All right. Well, I know I'm running the risk of losing our audience at the very beginning of our talk. So I do think number 2 is the best of the 4 choices, and I'll explain why. But again, I don't disagree. Those of you, I think choice D was the most common choice. I don't think any of these are wrong, but let's kind of go through them and I'll give you my thinking on it. So first, have you considered that if your diabetes was better managed and your hemoglobin A1C was lower, that your depression would be better? Again, it's true, as we just said. That's not a false statement. It just has a little finger wag to it that kind of gets under my skin of like, I'll teach you how to do this rather than let's open up space where you can tell me what your thoughts, your fears, your experience is. So we want to usually come at it from a little more of a person-centered, patient-centered, member-centered way than just that. Number 3, how does Hmong culture understand suicide? Again, I think it's a lovely question to try to understand someone's culture, et cetera. A little risk of speaking for a whole culture, and a little risk that you're implying it's a bad thing in Hmong culture, isn't it? It does have the risk of being a little bit distancing for the patient, the member. And the 4th, same thing. Don't disagree with that. The sun is important. You're trying to amplify those strengths. But again, it does have a little bit of a finger wag. Number 2 is the one that actually opens up more space rather than trying to close it down. It opens up the space to talk. And as I hinted at earlier, the sexual functioning in diabetes and depression is a major effect on people's lives, their quality of life, their experience of being human, and it could be a significant. And if no one asks, like people don't bring that one up on their own. And often I'll just own it. The medical professionals that they interact with don't ask as much. What a wonderful way to build relationship where you're opening that up. And it is sort of a part of a standard assessment of what's going on. So I actually do think inquiring about his sexual functioning could be a really helpful intervention. Again, I don't think any of them are wrong, but those 4 choices, I thought that was the one that was the one I would want to do next. All right, so you did. This is the case is modified. Obviously, I've combined multiple patients and histories and those kinds of things, but this did happen. So the patient, when asked, just sort of burst into tears and said he's terrified because he can't have an erection. He's really ashamed of it. He imagines that he could never date again. He feels really isolated, that antidepressant helped, but it made his sexual functioning worse, which is why he stopped it. So you then, now that you have this alliance and you could talk about it, first of all, he feels very safe with you now, which is a wonderful gift. Second, you can try to help him with it. So you refer him to the primary care provider, you can inquire about options for an antidepressant that doesn't affect sexual functioning. There are 4 of them that don't affect sexual functioning. And so there are options for him and options for treatment of erectile dysfunction, which can be common in diabetes and something that we can also help with. He mentions it seems like if the depression got better, it'd be easier to manage the diabetes. Again, he's doing the change talk now rather than us educating it. He's starting to think maybe I could get more on top of this if I weren't so bad. And so you support his change talk and gently agree with that. And most importantly, perhaps you ask him more about his interests. And he does write in a little bit about this hockey topic. And he tells you he previously volunteered with the Wild. I know, oh, interesting. What'd you do? And he starts to think maybe I could do that again if he called the volunteer coordinator back. And you ask more about his positive experience in hockey, and he kind of brightens and talks more about his son. So again, I think the more we're on the side of support, opening up space, let him do the change talk, let him think about what he wants for his life, et cetera, I think we're most effective.
Great job. Now let's move on to case 2. Dr.
All
Palmer?
right. I do this one too. Okay, so this is a patient I saw in clinic, type 2 diabetes. This one's not as hard. Okay, so, or not as obscure. All right, so don't stay with us. Don't lose the audience on case 1. She has type 2 diabetes. It's partially controlled on Lantus, 30 units at night. We'll talk about what that is. She's prescribed pre-meal and sliding scale insulin, but frequently misses doses. Her hemoglobin A1C is high at 9.2. She checks her glucose 3 or 4 times a week. Her depression is partially controlled on an antidepressant called bupropion, Wellbutrin. It's PHQ-9 is now 11, question 9 is 0. She lives with a supportive same-sex partner of 20 years. She works in sales for a local health insurance company, perhaps the one you work for. She likes to travel. They like to travel together as a couple. And she tells you that she just hates navigating the travel with all the meds, the needles, the syringes, the testing in the restaurants, the disposal of sharps. If she goes overseas, there's not reliable sharps containers in the restaurant bathrooms. Where is she supposed to do all of this stuff? She just hates it. And she doesn't say she's depressed. She clearly has strong interests and wants things from her life. She's not suicidal. She's not having sleep changes. She does have guilt about this affecting her partner. And you think, boy, she just feels demoralized. They don't have kids, and they were really expecting to retire early and travel more, but she is just preoccupied with this idea that she's becoming a burden to her partner. All right, so how do you respond to her? A, I'll open up the choices too, I think. A, it's okay to feel burdened by this, and I'm sure your partner understands and doesn't mind. B, you really do need to take your meds for both your diabetes and your depression. Both diseases can progress and worsen the other one, so even if it's hard, I hope you'll keep taking them. C, tell me more about how sometimes you feel like you want to take your meds and stay on track with your diet, and other times it's harder for you to do that. And D, did you know they have some diabetes treatments that don't require injections? We'll give people about 10 more seconds to answer so we can at least just get a pulse of the group if everyone doesn't have time. All right, Jenna, should we see where people are? Oh, yeah. All right, good. So we're on track on this one. Good.
So before we get to the answers, we're going to talk about the treatment of diabetes. And what I want you to walk away with is that the treatment of diabetes is incredibly complex. Before we even get to the medications, we have lifestyle modifications. Here, you have to watch your diet. I mean, not too much sugar, but make sure you have a little bit of sugar. You absolutely have to be exercising. No smoking, that's bad. You need to make sure you have your blood pressure under control. You need to make sure you have your cholesterol under control. And then we need to monitor your diabetes. So let's make sure that you're checking your glucose. We definitely want a fasting glucose, but then make sure you also check it before you eat. And then we're going to need that A1C every 3 months or so. We're going to get that eye exam at least every year. We need to be keeping a close eye on your feet to make sure you're not developing any of those pressure ulcers that we talked about. We want to make sure that there's no protein in your urine, which might be a precursor to chronic kidney disease. And then again, checking the blood pressure and cholesterol. Now we get to the treatment. So let's just talk about oral therapy. There are so many options out there. It's hard for clinicians to stay on top of this, let alone our patients. And they're changing. Every day we see new recommendations, and it also depends on what comorbidities you have. You might choose something different for somebody who has underlying chronic kidney disease as opposed to somebody who has underlying heart failure. So incredibly complicated. That's just the oral meds. Then we have the insulins. Lantus, a long-acting insulin, is a common one we use, but there are many other insulins that we use to treat diabetes. So it's just important to remember that treatment of diabetes is incredibly complex, particularly for the members and our patients who have this. So it's important to remember drugs don't work in patients who don't take them.
So I pulled a few slides here from a consortium at the university around scientific understanding of medication adherence. So let's talk a little bit about how to help someone stay most adherent to medication and to the overall treatment approach, which you all have a major role in helping support your members in doing exactly that. So let's just ground ourselves. Approximately what percent of prescriptions are never picked up from the pharmacy? 20 to 30. Isn't that crazy? They just never picked up. Like, we're not even like to the point of putting a pill box together. They just aren't even picked up. What percent of medications for chronic diseases are not taken as prescribed? 50. Could be even more than that. Mm-hmm. An estimated what percent of hospitalizations in older adults may be caused by medication non-adherence? 10. A lot of people in our hospitals just because they're off meds, and many billions of dollars of avoidable healthcare costs, maybe 300 billion, related to adherence. So adherence and sticking with the plan is important, but how do you do that most effectively is what we're going to talk about here. So lots of reasons for non-adherence: complexity, health literacy, limited engagement and treatment decisions, cost, et cetera. There's a range for any given individual, and the answers are different for every individual. A cultural misunderstanding of member or patient and the health system. There's different reasons for each individual that can be important in non-adherence. And we think about what drives adherence. There's at the center the human experience of the member. What do they believe about their health? What do they believe about the relationship? Moving out from that, their social supports, their provider or patient interactions and those relationships, their interaction with their care coordinator, case manager, care advocate, the disease itself and the impact on that. And certainly for all of us, we think about the insurance coverage and what costs are for adherence. All of those things can drive adherence. So I think this group is well primed for this based on your answer to that quiz question. And I was pleased with the resounding support for taking an MI approach, which tells me you guys already know this, which is great. So we'll just reinforce what you already have learned is that the data suggests, the science suggests that when the member can articulate the change talk, things go better than when we try to tell them. And I say we, as a physician, we come from the worst of this tradition. There are physicians that learn to lecture patients about their smoking, about their weight, about anything, and that was medical practice for a generation. Physicians are coming around, but you guys tend to be ahead of the physicians on this one, which I'm grateful for. So we want to facilitate the patient sharing his or her experience, what active listening, reflective listening, acknowledging the experience, and then explore the importance and build the confidence around change and make a plan together with the patient. So are you familiar with the ruler kind of concept? This is the idea that how important is this change to you? And how confident are you that you could make it? So let's play this. Let's play this one out a little bit with Dr. Spilseth and I. We will fumble through, but let's take the case of the woman that was nearing retirement, frustrated by everything, on track sometimes, off track sometimes, and let's see if we can demonstrate those techniques. You may do it better. You guys in the audience may do it better than I do, but I'll be vulnerable and take the risk of trying to be the provider here. So good to see you, Sarah. How we talked some last time about your diabetes, and frankly, we talked some about your frustration with what's going on. Where are you at with that today?
It's just really hard. I want to travel, and what am I supposed to do with these needles? And sometimes it's just easier to maybe let it go and not worry about it for a couple of days. It can't be that bad.
Yeah, it sounds like a total burden as you think about it. When you think about following the plan you have, what makes you, on a scale of 1 to 10, like, how important is it to you to follow that plan?
Well, I mean, it's important. I know that it could lead to a heart attack or something. It's important.
Give it a number.
I mean, I want to be here in 10 years. I don't know, 7?
Okay. So it's pretty important. And you started to say there's some reasons for that. You wanted to be around, you care about your future. That's what makes it a 7. And what else makes it a 7? What other things raise the importance for you?
I still have a lot left to do, right? Like, I want to travel. I want to be with my partner. I want to see places I've never been.
Yeah. So like on the one hand, it's frustrating to have that not be but that's what you've been prepping for your whole life, was this phase where you really want to be able to do that. So it's important to be as healthy as possible for it. That makes sense to me. So sounds like it's pretty important to you. How confident are you in your ability to follow the plan?
I don't know. That's where I struggle. That's where it's just hard. Maybe a 4.
Okay. And what makes it that high? What gives you confidence that you can follow the plan?
Well, I know what I'm supposed to do. I know that I'm supposed to do the insulin in the morning and sometimes before meals. I know how to do that.
So you have strong knowledge of diabetes, of the illness, of the medication regimen that you and your doctor have worked on. So that gives you some confidence. What else makes you confident, or what raises your confidence?
My partner is supportive. She seems to understand that I need to do this to be healthy. She's supportive.
Okay. So you got a couple of things in favor. And it sounds like the challenge is that you're less confident that you can manage the sort of day-to-day details sometimes, that those get overwhelming is the biggest challenge for you.
I think that's it. It's just hard day in and day out to manage that.
Yeah, makes sense. Are there things that would make it less hard, or are there times where it feels more manageable?
Well, I think when we plan ahead, I know I'm going to be here at this time. When I know like, for example, I know that we're going to be at a restaurant where I'll be able to eat healthy, or I know that we'll be somewhere that is accommodating to diabetics, meaning that they have, the Sharps containers that I need and stuff like that. That makes it easier.
So if you plan ahead more and you're familiar, and it's more familiar to that, increases your confidence that you can. Yeah, that makes some sense.
Yeah.
Cool. Thank you. Good job. Good job. Try, and trust me, for those of you listening, I'm trying to bite my tongue of not giving her the suggestion, having it come from her, and because she's got the wisdom, she's got the ideas. So, how do you understand this disease? How do you understand the treatment? What's in favor of doing the treatment? What's in favor of not doing the treatment? It's okay to just open up space here and try to partner with somebody. So, and like I said, some of you on the call have advanced MI training and might have said things even more effectively than I did. And others of you, this is still a little bit new for, but the idea is, and I think those confidence and importance rulers are kind of a nice technique just to help elicit the change talk and what somebody's thinking about. And yeah, sounds like she came to her own conclusion that if she can plan a little more effectively ahead of time, and that having a disease like diabetes may require her to plan a little bit more ahead of time, but it came from her, not from me, which was the goal. So, how does your approach to medication change when your depression is better or worse? Love that question. Because depression for many people can be chronic. It can come back again. I didn't ask her that, but it could be a lovely question to also think about how we layer that into the motivational interviewing. And we can address the specific barriers. I mean, there are some practical considerations. I tried to stay with my MI hat, but I think if I were her partner, clinical partner in this for some time, we would have a language around what are the barriers, et cetera. And she came up with some very specific barriers for adherence that we can try to work with her on. And just from a practical standpoint, I mean, thinking of diabetes, some people are really scared of needles. Some people are scared. I mean, all of the stuff that we have to anticipate, and we can help with things like reminders and the practical nature of this. And you guys are pros at that part of this work. And so making medications a habit, organizing meds in a pill box, storing meds together, linking what time of day you take, we're going to link meds with a behavior like toothbrushing. Well, I always remember to brush my teeth. If I have the meds next to the toothpaste, I will then remember to take the meds. So you can link it to something that is already an established behavior. You can link it to a meal, which often helps as well. Those kinds of things where you link the behaviors. Again, not sharing anything that's unfamiliar to this group, but again, helping somebody as they're starting to think about that. Once they're articulating the change talk and they're like, okay, I really want to work on that, then we can sidle up to them and partner with them to help them do that. Plan for away from home, single compartment pill carriers, where you're going to carry your meds, how you're going to fly on an airplane with meds and make sure they're not in your checked baggage, what you're going to do in cars and all those things. So just sort of planning ahead and anticipating, which for a lot of people is a pain. I think that's the rub in this particular case is she doesn't like to plan ahead, like to really think of all those details. I mean, who wants to? It's just like, push that out of my mind. So in her case, trying to do some planning ahead could be really helpful. Again, lots of specifics that you guys would be able to do. Keep going. So on this case, we agree with you that C is the most opening of the question. So A, it's okay to feel burdened by this. No opposition to this. I'm sure your partner understands and doesn't mind. Actually, we're not sure of that. And false reassurance really doesn't go anywhere useful. I don't know what her partner thinks on that. You really do need to take your meds. This one, we're back to finger wagging and educating. And it's true. It would be good if she took her meds, but she's going to need to come around to that. So C is what I think you guys liked. I think 90%. Tell me more about it. Sometimes you feel like you want to take the meds, and sometimes it's hard to do that. So kind of a classic MI opening. And D, I don't object to D. That was the second most popular choice. It is factually true. Like there are options out there. So those of you who picked D, I don't think that's an incorrect thing to do. I just think you're trying to problem solve rather than open up space to work with the member. But sometimes practical stuff is useful. So I'm not concerned with if you had suggested that. I don't think it would be a bad thing. All right.
Moving on to our final case. This one's mine. Here we have a 47-year-old African-American woman seeing you for case management. She has type 2 diabetes that is controlled with oral medications, and her hemoglobin A1C is 7.2. Her depression is treated with fluoxetine, and her most recent PHQ-9 is 7. Pretty good. And she says to you, I'm so glad to be getting back to normal. In scanning her record, you see that she was reasonably well controlled as she is now in early 2019, but by November of 2020, her diabetes was poorly controlled with a hemoglobin A1C of 9.2, and her depression was significantly worse with a PHQ-9 of 17. So the question is, and we're going to put up the polling, which of the following would best explain her worsening and then subsequent improvement? 1, she had a change in PCP during that time and had to build trust with a new provider. 2, she lost her job during the COVID-19 lockdown and became food insecure, a feature that improved when she received subsequent stimulus checks and eventual reemployment. 3, she had a depressive episode, that required hospitalization in 2020, and the hospital food was hard for her to manage with her diabetes. 4, she experienced natural worsening of her diabetes in 2020 with corresponding worsening of her depression, and it took time to determine a more effective regimen for both. We'll give about 10 seconds for these questions. Okay, what do we have? All right, so the predominant answer was number 4, but then we had a little bit of number 2. And we're going to talk a little bit about this and what might have happened. But before we go there, we're going to talk about the cost. Oh, maybe I have to close this. My apologies. Here we go. There we go. The cost of diabetes. Total annual cost in 2022 of diabetes was $412.9 billion. That's $306 billion directly related to medical costs. But then we also have to be thinking about the amount of the cost related to indirect costs, such as not being productive, not being able to be in work, having to be in the hospital, things like that. That was $106 billion. Diabetics have 2.6 times higher medical expenditures than patients without diabetes. On average, women spend more than men. Our Black diabetic patients pay the most in direct expenditures. Now, one positive thing is that the Inflation Reduction Act did cap the cost of some insulin to $35 per month, but that was for Medicare only. Now we're going to talk about food insecurity in diabetes. Food insecurity increases the risk of developing diabetes. We have to remember that food insecurity is not just lack of access to food, it's lack of access to nutritious food, to the foods that we want our members and our patients to be consuming. Research has shown that those with food insecurity are 2 to 3 times more likely to have diabetes. Furthermore, it increases the risk of complications. We know that our members with food insecurity have higher A1Cs. They're more likely to have diabetes-related complications, hospitalizations, and poorer mental health. Finally, we think so frequently about high glucoses, but we also have to remember that sometimes our members and patients with food insecurity might skip meals. When you're taking some of the medications that we use to treat diabetes, this can lead to dangerous hypoglycemic episodes, which can actually lead to potentially death. And so there are many ways that food insecurity impacts diabetes and depression. I think this one was you. Yeah.
Yeah. On the psych side, this is important. So we learned this during COVID, which was the origin of the quiz question, that when COVID hit, population level anxiety and depression went up. I think most of us can remember feeling just that day-to-day grind of things not feeling right inside, and the whole population had some increase in anxiety and depression symptoms. What was striking is when the first stimulus checks started going out, and we saw food in first thing that people spend their money on is food for their family. And we saw food insecurity start to go down as people had enough money to afford food. By the way, people make good food choices if they have the ability to afford food. And so just getting people access to food becomes the key thing. But food insecurity dropping, we saw about a 20% decrease in population level anxiety and depression with those stimulus checks. So food insecurity really can drive depression, just as it can fuel difficulty in treating diabetes. And considering the social context for our members, I think becomes really important based on that data. So a few access options. Your plans have other access options that are available, but ways that we can try to support our members. These are some of the options, and I think all the various plans are trying to think about how we support members getting food. But from a depression perspective and from a diabetes perspective, that access really is a key.
So going back to our case, which of the following best explain her worsening? I hope that we've kind of impressed upon you what an impact that COVID-19 lockdown had, and most importantly, what an impact just having access. Having access to food is incredibly important, both for diabetes and depression.
And no objection for those of you who thought 4, and certainly that's possible too. 4 is a plausible thing that you could have worsening depression, you could have worsening diabetes, and took some time. But given that it came so precipitously, I mean, this was a change from normal. You almost do think 2 is probably the better option because it was just something external happened that really fueled things. Awesome. Thank you guys for the, I say guys, I need to work on that. Thank you to the audience for your engagement and participation. Appreciate it very much. We've had a few questions come in the chat, and feel free to address them to hosts and panelists, and we will try to take them. Comment that was made that I just a lovely comment from a participant named Lisa. I appreciate the discussion and value of sexual well-being for somebody with diabetes and depression, but I wonder if this discussion is had equally with our female patients. Very important point. This may be an unexplored reason for poor adherence or discontinuation of depression meds, and women may be even less forthcoming about sharing the side effect. 100% agree. So we had a male example because that happened to be the case that we were working on, but the effect of antidepressants on women is the same as men. It can affect all parts of the sexual behavior, including arousal and desire and orgasm, all 3 aspects of sexual behavior, and all can be negatively impacted. And so we ask about all 3 parts, and we can try to have that conversation with our patients and members, female, male, both. It's important that we open up space for that. Other comments? Or questions?
Dr. Palmer, someone did ask about the resource for this.
Yeah, we can. How should I best get that? It came from a produced slide deck from a consortium, and I can grab the full resource for people. How can I best share that with people?
If you could send it to me, then I can have it sent out with the evaluation reminder after the event.
Yep. So, and for the whole group, the comment had to do with these medication adherence statistics, where those come from. So we'll get those shared out. Any other questions or comments? Yes, you get CEU for this.
Oh, there's a question.
What effects are you seeing on this from the topic from increased use of GLP-1s? Or I think you mean, GLP-1s.
Yep.
So absolutely, the GLP-1s, this is a huge topic of conversation. I will say that a lot of the discussion has been around how do we equitably make sure that all members have access when it's appropriate. I specifically haven't seen data on how it affects mental health. We certainly know that it is a great medication option for our diabetic patients. And I would suspect with the improvement in diabetes that we would see improvement in depression, but I haven't specifically seen data looking at depression. Dr. Palmer, have you?
Yeah, this is such a frustrating topic because these meds have some promise. They certainly have promise for diabetes. They do have promise for, actually cravings more broadly. It's being studied within psychiatry of people who, I had a patient that was on them and he said, I just didn't feel full. And so he would drink or he would eat more or he would do whatever he did. And when he's got his GLP-1s, his urge to drink has gone down a lot. So we're starting to see some very interesting data coming out of these meds that could be helpful, and they are priced in a way that make them prohibitively expensive. And that is just a terribly frustrating aspect, especially in the US. They're over $1,000 a month in the US. The next highest country, Japan, $169 a month. We are being charged a lot for these meds, and that has been a painful part of managing this.
Couple of questions. Lots of docs still don't screen for OSA until things are really out of control and can affect mood too. Absolutely. That is one thing that we should have mentioned in there. Screening for OSA, also known as sleep apnea, can play a huge impact on many areas of health, including mental health. And these are patients, a lot of times, when I talk about OSA, it's one of the silent killers, right? So we see patients who go untreated for their sleep apnea, having higher blood pressure, higher rates of hospitalization, higher rates of stroke. This is an area where we need to make sure that they're being screened appropriately.
Love the comment about our language that Dr. Spilseth or I or both may have used the word diabetic during the conversation. Apologies for that. We all recommend that we use the word people with diabetes as best we can. Thanks, Katie, for calling that out. Oh, good. So one of our participants had a member with diabetes and depression, and this was entirely relevant. So just happened to be exactly the right potential case there. Dr. Spilseth, how do you think about pre-diabetes broadly?
Yeah. So pre-diabetes, here I want you to think about all of the opportunity we have to try to prevent that patient from developing diabetes, right? But we have to recognize that a lot of those interventions could potentially be stressful for those members and those patients. And so we do need to make sure that even in our patients with prediabetes, that we are thinking about, is there underlying mental health disorder that needs to concurrently be addressed so that we can do our best to prevent this member from going on to develop type 2 diabetes. So does this information apply? Absolutely. But here I would say we maybe even have a little bit more opportunity, particularly if we intervene early enough.
That's good. And then a basic medical question, Dr. Spilseth. How about for OSA or other sleep disorders, options other than CPAP that we consider, or is that it?
No. I would love to come back someday and talk about sleep apnea, but there are other options for sleep apnea. There are some oral appliances that can be used, and then there's also the hypoglossal nerve stimulator that is appropriate for some patients. The true and tested one, the one that we know works best, is the CPAP. And I know that there are a lot of patients and members who don't like the CPAP, but it is really kind of the standard of care at the moment. But there are a couple of other options that you could consider trying in your patients who are adamant that they will not use CPAP. I've seen that frequently.
You want to talk about alcohol and diabetes?
Yeah. So this is a great question. Can alcohol be a major contributing factor to the diagnosis of diabetes? Anything else outside the scope of healthy eating, weight management? So one thing that we don't think about with alcohol abuse and use is the amount of sugar, the amount of calories that is in that. And so I have seen with my diabetic patients that the diabetes is very difficult to manage when we're consuming alcohol excessively, just because of the the glucose spikes and then also drops as well. So like we try to treat them to get those high glucoses under control, and then maybe they don't have a drink, and now all of a sudden they're bottoming out. And so it can be really difficult to manage. Yeah.
So I think the general guidance is that for type 2 diabetes, alcohol can be used if it's in moderation.
Yes.
But in terms of risk, it has to do with particularly things like beer or sweetened alcoholic beverages where the sugar content is high, and that can really be a challenge as well. Okay.
Absolutely.
Yeah, shifting back earlier in the questions, there was a question about for Medicare only patients, what's the best way to determine what's covered for diabetic care?
Yeah, and diabetes education, determining the coverage, it is really tricky. I completely agree with you. This is where I would rely on, and so when you say Medicare only, I'm wondering if you're meaning just straight Medicare fee for service. The vast majority of our patients are moving towards Medicare Advantage plans. And so those plans are going to be different depending on who the insurer is. That being said, there are certain things that every plan is required to cover. And so you would have to refer to the individual plan to know what exactly is covered. And I'm sure that any of your medical directors at your health plans can help you navigate that.
I'd call one of our case managers to answer that question. But we may not be the world's best people to answer. So if others have comments about how they might approach that benefit determination, feel free to throw it in.
And I will just say that there's a lot of moving pieces with that too, particularly with the continuous glucose monitor, the CGM, like you called out, continuous glucose monitors. Lots of moving pieces with that. And I wouldn't even just say Medicare. I would extend this to Medicaid and even commercial products, right?
Great. And I know we're really close to the end, and I do have one quick question, but I don't know if you can answer it. So how does a physician find space for the motivational interviewing questions when you are so limited in your time? Is it just over time? Like you just develop the relationship? I'm sure it's just hard.
Yeah.
I totally respect how busy physicians are, especially primary care physicians, nurse practitioners, PAs. The clinical teams are very, very busy. These techniques don't take longer. It's just not that appreciated if you are focused on eliciting the change talk from the other person rather than you explaining to them the importance. You're so much more effective, and it doesn't take longer in the office visit to do that than it would for you to be the person talking. It just is way more effective if you can flip it as much as you can. So you're going to have better outcomes the more you're able to practice it.
Awesome. Thank you. All right. And I know Jenna put some information in the chat, but also you can advance the slide here, Dr. Spilseth. So we do have an upcoming webinar from NAMI. Is coming up pretty quickly, July 17th. And this will go out, and you can click on this and join this. We're really excited about them and presenting on overcoming the unique barriers to care for people with depression and diabetes. So that's July 16th. And also, I know Jenna had put in there CEUs. In order to get a CEU, you will get a certificate of participation, and you would have to go to your nursing board to be able to get the CEU. But the evaluation link will come as soon as you sign off, and then it will also be available about a week after to give you more time to fill it out. And then also there's a link to our great information on the Strata site for our website there. Again, thank you to our presenters for the great webinar, and I really appreciate your time today, and thank you everyone for joining on this very important topic of diabetes and depression.
Thank you all.
Thank you.